As we observe World Stroke Day today, I have the privilege of introducing Dr. Vikram Huded, interventional neurologist at NH Health City in Bangalore. I met Vikram many years ago, and interestingly, he taught me that heart is not the only organ where interventions can be done. They can do much better perhaps intervention on the brain, and I was amazed at the way they were opening the blockages in the brain arteries. Welcome to the show, Vikram.
Thank you.
Thank you very much for participating. I would like to introduce Dr. V.R. Rao, who is the head of the Department of Physiotherapy at the Narayana Health City in Bangalore. I am a surgeon, and my colleagues are, as surgeons, we are very vulnerable for backache and neck pain, and whenever we get this problem, first thing they do is to consult Dr. Rao. Thank you very much, Dr. Rao, for being here today. I am very happy to introduce Smita Karen Matthias. She is a speech and swallow specialist, and she taught me a very interesting lesson. She told me that people can have a stroke and may not have any physical manifestation other than just not being able to swallow. Can you believe somebody who looks normal, walks around, talks like a normal person, just not able to swallow? And Smita has treated a lot of these patients, and she has given them very good quality of life. So, thank you very much, Smita, for attending this show. We have received a lot of questions, thousands of questions. Unfortunately, my colleagues here, Sumanto told me that I have only half an hour to interact. So, without wasting much of your time, let me straight away come to the first question asked by Sarwar Jahan Hank from Dhaka. He wants to know, the question is to Vikram. Vikram, what are the risk factors for stroke? And Sarwar is 50-year-old.
Okay. So, the most common risk factor for stroke is high blood pressure, diabetes, high cholesterol, if they are smoking, and alcohol, excess alcohol consumption, obesity, and if they have got a specific cardiac risk, like if they are having atrial fibrillation or valve patients. So, these are the risk factors for stroke. And recently in BMJ journal, it has been published that if a person works for more than 50 hours per week, the chance of stroke is increased by 33%.
Vikram, I am surprised that are you saying that we shouldn't work for more than 50 hours a week? I can't believe it, but I respect the BMJ. What are the other risk factors, Vikram?
So, as I said, smoking is one of the strong risk factor for both heart attack and stroke. High blood pressure, uncontrolled diabetes,
okay.
Obesity, lack of exercise, and fried food, and if they eat less vegetables and fruits.
Okay, okay, okay. Vikram, after listening to you, I feel half of the Indian population is vulnerable for developing stroke, because virtually all the risk factors you are talking about, unfortunately, we are very vulnerable. So, added to that, if people start smoking, obviously smoking or tobacco in any form, it is dangerous. Thanks, Vikram. Let me come back to the next question. It's from Mr. Bulu, again from Dhaka. What can be done if I suffer from stroke? He wants to know, if he develops stroke at 12 o'clock at night, what he should do.
Yeah. So, to answer that question, basically we should know what are the types of stroke. So, there are two types of stroke. First one is ischemic stroke, which accounts to 80% or 85% of stroke, where there is a blockage of blood vessel to the brain, either by clot formation inside or emboli going from the carotid artery or from the heart. So, the other 50% accounts to brain hemorrhage. So, earlier 20 years back for stroke nothing was done, just they used to give aspirin, they used to do scan, and nothing was done. But now with recent advances, many things can be done in acute stroke, like if they have got blockage in the brain, if they identify early, And if they come to a hospital where all the facilities for stroke management is available, so if they come within 4.5 hours, we can give a clot buster injection after ruling out some contraindications like if there is any bleeding inside the brain. So we can give simple injections, or even if we have a comprehensive stroke unit where everything is available 24/7, we have facility for hybrid cath.
1 second, Vikram. Are you telling me that somebody develops a stroke and one side of the body is paralyzed, they come to you within the first 1 hour or 2 hours, you can reverse the stroke?
Yes, sir. That's what. Now,
What percentage of the patients you can reverse the stroke?
around 60% of patients can walk home and join their job. So that is the.
1 second, let me clarify this, Vikram. You are telling me that somebody develops a massive stroke on one side of the body and they come to your hospital and you do an intervention and they can go home, they can walk back home. Are you telling me that?
Yeah. So we will come to a scenario. If it is a large vessel occlusion, only 20% of patients will recover.
Okay.
Whereas if we intervene and remove the clot out, the 60% of patients.
60% of the patients can walk out.
Yes.
That's amazing. That is really, truly, truly amazing. Yeah. Yeah, I think there is a problem with your mic. Yeah. Let me come to the next question. This is this question is for Dr. V.R. Rao. The question is from SM Ahansul Islam from Bogra in Bangladesh. He says, my right side is paralyzed and right hand is half drawn because of stroke. Is there any way that I can recover from this? Dr. Rao, he wants to know whether he already had a full-fledged stroke and is suffering with the debilitating weakness. Is there any way he can recover?
Yes, sir, definitely. But first, we should know what stage the condition is. Like, is it an acute or subacute or chronic? If it is acute, definitely we can rehabilitate his hand. The only thing is, now the entire body is like a Xerox copy in the brain. That is called as motor homunculus, or sensory homunculus. Both we will be working upon as to develop the reflexes initially when hand is not functioning fully, and then we will fine tune that towards the task oriented goals. So that is definitely possible, sir.
How long the whole process will take, Dr. Rao?
So that's a difficult question, sir, but I'll try to answer. The rehabilitation itself is a process, sir. It is not an event. And most of the patients, they will think that the physiotherapy or rehabilitation professionals are doing the therapy and that ends. But actually, what I feel is we should skill transfer to the patient in the community level also, where he will be able to continue what we, given the tasks or the physiotherapy goals or whatever. So that will really help, sir. So the full integration of him into the society depends on how we skill transfer to the patient and patient relatives.
Supposing the patient develops a stroke and he is recovering in the hospital, then he starts physiotherapy. Is that the time to start the physiotherapy, and is that the best time to get the best outcome? Or he develops full-fledged stroke and he goes home, doesn't see you for 3 months or 6 months, then he comes back. Is there any difference in the outcome if he comes to you soon after the stroke compared to later on after a few months?
Yes, sir. Soon after the stroke, we can start early. Early rehabilitation is very important to bring out the patient out of the difficulties, especially hand functions, because hand is a critical thing to recover. The entire, because gait or lower limb other functions will be easy because there is a weight bearing and there is a functional importance and goal and all that. But hand always, it is a last thing to be recovered. And sometimes if we don't start early, that may not recover completely also.
Okay. Dr. Rao, I am asking you a straight question. Somebody develops a stroke, he comes to your hospital and you are treating him from day one. What are his chances of recovering from the weakness compared to somebody who didn't get the kind of a best attention what he should get?
80% he can recover, sir.
You mean
If
to
we
say
start
80?
early, yes.
That's amazing.
Yes, sir.
That's really, really amazing. Great job. Thank you very much, Dr. Rao.
Thank you, sir.
Hi, Smita.
Yes.
There is a question for you
Yes.
from Hubali Gupta from Guwahati,
Okay.
Assam. She says, my mother had 3 cerebral stroke within a span of 10 months and now she has lost the ability to speak. Will she get her speech back, and if so, what percentage will she recover and will she be able to talk?
This is a complex question because speech as a function is very complex, and it is one of the most complex functions which humans have when we compare to other animals. So, if you look at moving, walking, digestion, excretion, other forms of life have it, but speech and communication is one of the higher mental functions which we as humans have. So, as
Thank you very much for teaching
Yes.
us, Smita. It's very interesting.
So, the thing is, this lady has had multiple strokes.
Okay.
So, the first thing is to know where exactly these multiple strokes have happened. Okay. Is it only targeting only the speech area?
Okay.
And speech is the clarity of speech, motor
Okay.
programming, motor control and execution.
Okay.
Second thing is the understanding of speech. Can the patient understand what somebody is talking? Can he read? Can he write? Can he calculate? So, basically all his higher mental functions. So, we need to know when this lady had her strokes, which were the parts of the brain damaged. Second, we need to evaluate how long she took to go to the hospital and get her acute treatment done, and then based on that we start the rehab process. So, if she's already had her acute rehab, then definitely her chances of improving are much better, and we need to work on different functions. Based on our tests, we are able to figure out what are the language and speech functions affected, and based on that she needs speech and language therapy.
Smita, let's take a very interesting scenario.
Yes.
Patient came to your hospital
Okay.
and patient is treated by your specialist
Yes.
and you are attending the patient from
Yes.
day one.
Yes.
What are the chances of her recovering her speech function? In an ideal environment, what percentage of them will recover their speech function?
So, here again it is a complex question because sometimes
Generally,
the stroke is complicated
Yeah.
and the patient lands up with breathing difficulties with the tracheostomy.
Okay.
So, there developing the speech function will be delayed because
right.
voice itself is not being able to be
Sure.
produced. So, based on that, so the earlier the patient comes to us, then we work on first production of voice and then language as a whole.
Okay, okay. So, generally in an ideal patient who had a stroke,
Yes.
what percentage of them can recover their speech function?
70 to 80% if they come to us early,
Early.
and based on big damages versus small damages.
You
So,
know,
Dr. Vikram will, based on how much they can prevent damage, based on that function we take over the rehabilitation aspect.
It's very heartening to hear, Smita, that 70 to 80% of the patients can get back their ability to speak. It's very reassuring.
It's a long process, sir, because speech is a very high cognitive function, and when I say speech, it means he has to speak in sentences, he should be able to work in a pressure situation, he should be able to converse in a meeting. So, speech as a whole is very complex. It can be a person who's retired and at home, so he has a very easy environment to deal with, but a person in a productive age, he's the problem. Speech for him is very competitive. So, he has to take phone calls, he has to type messages, he has to answer emails. So, speech and language functions are tested at different instances. So, that's where they struggle with pressure situations and how to communicate effectively.
Thank you, Smita. It's very heartening and reassuring to hear your assurance that significant number of them can recover if they get the proper care. Now, going back to Vikram, there is a question from Mr. Shamshul Mundal. He is from Bardwan, West Bengal. I know all the districts of West Bengal because I lived there for many years. The question is, Vikram, how can I know that I am getting a stroke? What will be preventive measures for stroke? How to prevent stroke? This is his question.
To answer the first question, so how I will know that I am having a stroke? See, compared to the heart attack, where the pain is a predominant symptom, but a stroke is a painless disease. So because of that, many patients won't recognize that they are having stroke. So, and the second thing is the variety of functions. Brain has variety of functions, so it controls the whole body. And so some symptoms they can miss, like if they are having confusion, they can miss that it can be as part of stroke. So for general people, there is an acronym name which is FAST to remember that these are the symptoms of stroke. F stands for facial asymmetry. A stands
One
for
second, what is facial asymmetry, Vikram?
means if we ask them to smile, so one side of the face goes to one. So that can be a symptom of stroke.
Stroke.
And arm, A stands for arm drift or arm weakness. If you ask them to lift a hand, one arm goes down, or there may be weakness on one side. S stands for speech disturbance.
Okay.
Speech disturbance can be dysarthria, or they can lose the speech, or they may talk irrelevantly. So
Okay.
this is stands for S. T stands for time to rush to stroke ready hospital.
Okay.
Because every second the blood flow to the brain is blocked, we lose around 33,000 neurons.
Okay.
So,
Okay.
so time is important. Like as soon as they develop these symptoms, they should rush to stroke ready hospital. They should not waste any time.
You see, the problem is, Vikram, I spent my many years of my professional life about educating people about the importance of time. 6 hours following the heart attack is the golden period. After 6 hours, you may do whatever you want, you may spend millions of dollars, you can't revive the heart. Similarly, when somebody develops a stroke at 12 o'clock at night, the scenario is he has no pain, so he is not bothered. And you are suggesting that he shouldn't sleep it over and come next day morning. What is the ideal time or the golden period for them to come within that period so that you can give the best time, best outcome?
So as I said, earlier the better, because every second we lose around 33,000 neurons.
Every second
Every
you lose
second
33,000 neurons.
So means some patients may call their family doctors, and family doctor may be sleeping, they may not lift the phone, they may call their relatives. So that's where they lose time. So if any of your friend or relative, or if you develop these symptoms, so they need to rush to the hospital immediately. They should not waste any time. IV thrombolysis can be given up to 4.5 hours, and endovascular clot retrieval can be done up to 6 hours. But again, earlier the better outcome will be better.
So your advice is, if somebody develops a weakness of either their one part of the face turns to the wrong side, they are not able to, there is a asymmetry on the face, or they are not able to lift their arm, or they are not able to speak, you suggest they should not wait calling people, just rush to a stroke ready hospital. What is this stroke ready hospital, Vikram?
Stroke, if a patient comes to, for example, our hospital, once he reaches to casualty, we start a stop clock. We have a sister who is there 24/7. There is a stop clock, and we start the stop clock. And immediately one sister will take the blood samples to the lab, and they will give the reports in 20 minutes. We shift the patient to CT. Meanwhile, we will be asking the history, when was the onset.
So that same time you are talking to the patient when the patient is wheeled into the CT scan.
So
Okay.
once CT is done, we rule out the bleed. We speak to the relatives regarding what can be done, and we start the thrombolysis. Like in worldwide.
What is thrombolysis, Vikram?
So thrombolysis whenever there is a blockage in the brain by the clot, we give a clot buster injections, which we give, the clot will lyse and the brain will start reperfusion.
Okay, okay, okay.
So the main thing is international standard, they say once the patient enters your hospital door, you should give that injection in 1 hour time.
1 hour time.
So whereas in our hospital, in some cases, we are done in 25 minutes.
25. Excellent.
So
Good.
this facility will not be there in all the nursing homes and hospitals. So that's why each zone should have hospital which all the public should know or ambulance driver should know that it is stroke ready.
Excellent. I think it's a great idea. I think hospitals which have all the infrastructure, they should prominently display at their entrance that we are a stroke ready hospital. Yeah, because as the country gets older, we are going to see more and more strokes, and it is really unfair for us to not to offer the best possible care to recover their precious brain. Thank you. You did mention about intervention. What exactly is the intervention on the brain, Vikram? I know of intervention on the heart. Can you just describe what exactly you do with the brain?
So there are many types of interventions which can be done in stroke, whereas hemorrhagic stroke, whereas in ischemic stroke, if there is a blockage in the large blood vessel, we recently in 2015 American Stroke Association has class 1 evidence for stent retrieval. Here we put a stent inside the clot and we remove the clot with the stent. Whereas in coronary we have to put a stent inside the coronary arteries, whereas in brain it is not required. So the chance of restenosis, the chance of bleeding inside the brain because of double antiplatelet is less and so. So this is a landmark modification or treatment which has come after 20 years after IV thrombolysis. And in US it has made a big name because in 2015 it has come as a standard of care. So it is required.
Can you describe again, somebody comes to your hospital with the paralyzed one half of the body and you do the CT scan, it shows there is a blockage. Then what do you do?
So if we do CT scan, with that we do CT angiogram.
CT angio, fine.
So if depending on CT angiogram, like if there is a large vessel is blocked, if they come within 4.5 hours, we start the IV thrombolysis and shift the patient to the cath lab. In cath lab,
so the hospital, a stroke ready hospital should have a cath lab.
Yeah, yes sir.
Okay, you need to have a cath
Yeah.
lab.
Now
Okay,
in
okay.
2015, it is one of the standard of care.
Okay, fine.
So once we shift to cath lab, we document that the vessel is occluded, and then we go inside that vessel and put the stent retriever and remove the clot out.
So you put a stent inside the cerebral artery, and then you remove the stent and the clot together.
Clot together.
Right.
And
That's very
sometimes once we remove the clot, the patient will lift the hand. So that is a magic.
It's very reassuring, Vikram. I'm so happy to hear, because see, when you see somebody who had a paralyzed one half of the body, you see able-bodied men and women who are young and they have one side of the body is paralyzed. It's very sad to see, because no matter what you do, you can never retrieve, right? So you are saying that as you remove the clot, they are able to lift the hand.
Yeah, some of the patients.
Yeah. God bless you, Vikram. Keep doing it. God bless you. Now, let me go back to Smita. Smita, there is a question from Pawan. Pawan is from Solapur. He says, my brother aged 45 years was working as a HR manager, had a stroke. He has breathing and feeding tube for the past 2 months. He has a problem with swallowing. Can anything be done?
Yes. So here we have two problems. We have a patient on the breathing tube, that is the tracheostomy tube, and second is the patient has a feeding tube. So we need to evaluate what is the primary problem here. Does the patient only have a breathing problem and that's why he has the breathing tube, or is it a swallowing problem and the breathing tube is kept as a safety valve? So this is something we need to evaluate. The second thing is, what kind of feeding tube does he have? Does he have a feeding tube which is nasal in nature, which will be removed earlier because the patient is going to recover, or it is a brainstem stroke, the controls for swallowing are affected. So in that case, cranial nerves, brainstem control. So that's going to be a longer process. So there the patient may have a PEG, which is a stomach feeding tube. So these are things which we need to evaluate. So with this, there are different kinds of tubes which the patient has. So when we identify that there's a swallowing problem, we suggest that a better tube with special cannulas be placed with the cuff and a swallowing tube, so we can regulate how the process of swallowing is taking place. So the patient can have two problems. It can be either motor or sensory or both. The patient can't even sense that there's food going in. So because of that, he's at a risk of choking. Secondly, the patient can have a speech problem. He can't understand that food is going in. So you have to treat speech, language, swallowing all together. It can be only a swallowing problem. So the patient is like us, sitting, talking, but he has a feeding tube. So we need to work on the sensory input, so the brain gets to know that there is something coming in, and then work on the motor control, so they can program and move the muscles in coordination. So there are a lot of patients, they can do it, but they're incoordinated. So they have a risk of choking, and choking can be life-threatening. So that's why swallowing has to be taken very, very importantly, crucially.
Smita,
Yes.
if this patient comes to you
Yes.
with a problem,
Yes.
how long you will take
Yes.
to rehabilitate him so that you can restore his swallowing and the other functions, approximately?
Approximately. So it will take us a few months for certain patients.
Okay.
It can take us a few years also for certain patients who couldn't reach a stroke-ready hospital. So there we will start with first tracheostomy care and continue maintaining his nutrition through the feeding tube, okay, and then work with his swallowing. So then start feeding him orally along with the feeding tube, and then we have different types of tests where we can see what happens during swallowing. So you can use endoscopy or fluoroscopic procedures to evaluate, because swallowing is a dynamic process. And then slowly, as he is able to maintain his nutrition on a safe consistency. Okay, so you may think water is the safest consistency, but water is something which is the most dangerous and which can go into the lungs and affect the patient the most. Okay, that is one thing which I would like to sensitize people. Be careful. If you see somebody having a stroke, drooling of saliva, facial asymmetry, unclear speech, you know that his musculature is affected and cannot handle his own secretions. He can choke on his own saliva. So please don't go and just give him 1 cup of water. He can choke on that. So we need to evaluate what is a safe consistency and then decide whether he needs to be on the tube immediately, or we can work with him on the nasal tube, and if it's a long term, then go on to a long term tube. So these are technical decisions we need to take.
Thanks, Smita. But anyway, I am very happy to hear that somebody who has a serious problem is swallowing.
Yes.
With the rehabilitation, you can restore
Yes.
their capacity to swallow. That's a good news. Thank you very much. Now, coming back to Dr. Rao. Dr. Rao, there is a question from Dhruv from Mumbai. He is asking, what is stroke rehabilitation? What is stroke rehabilitation?
So, stroke rehabilitation is having the range of services which starts with the acute stage, like how Dr. Vikram explained us, how to recover the patient from the clot and formation, immediate recovery. And then initially the acute stage, we all concentrate on the medical stability of the patient. And then the second is the second stage, subacute stage, where we will be concentrating more on the functional outcome of the patient, functional goal oriented. And third is the chronic stage, where again the skill transfer into the functional, where he is going to go back into society or working where, that kind of platform. So all these 3 stages, as early as possible, what we start. It includes physiotherapy, which is mainly concentrating on the movement and function of the patient, and occupational therapy, again the hand functions and rehabilitation, speech and pathology, again the swallowing and nutrition part of the patient. With all this, even the psychiatry, the clinical psychology also will work, because the young people, we have seen A lot of people are suffering with the stroke young. So when they go back to their working environment, how they are going to get adjusted, or in the society when they negotiate, usually the activities of daily living will be divided into instrumental activities of daily living and basic needs, like the grooming and all that. So we will be training in the rehabilitation setups for both the aspects, goal oriented.
It's very, very interesting, Dr. Rao. So essentially, management of stroke is not about just one hero like Vikram. It's about a big team of people.
Yes, sir. He starts and we ends.
Okay.
Main thing is brain cells can't regenerate.
Okay.
Once brain cell is dead, that part of the brain stops functioning. So that's why in the acute, if they come within the golden hour, we are saving the amount of brain cells.
Okay.
Like if 100 people are doing a job, if 20 leave the job, so how the brain recovers is the remaining 80 people has to do more work.
More work. Okay.
So that's how they recover. That's where the physiotherapy and speech therapy will come. But to save the number of people leaving the job, it's our day.
That's a very interesting comparison, Vikram. Vikram, I keep hearing about people talking about TIA, and it's a very common problem because as a heart surgeon, I do listen to patients talking about having had a TIA, right? Can you just explain what exactly TIA is?
Yeah, TIA is a transient ischemic attack, also called mini stroke.
Mini stroke, okay.
So some patients can develop the symptoms of stroke like weakness on one hand, speech disturbance, and it lasts for a few minutes to 1 day time, and they recover. So they will feel that because I slept in different posture and this has happened, or I drank something and this has happened, and they neglect these things. So these are the warning symptoms of stroke. So if they reach a neurologist on time, and they evaluate if there is any blockage, and we can prevent a bigger stroke. So that's why TIA is a warning symptom. Whereas chest pain, if you walk, you will develop chest pain. Whereas brain, this is the only symptom which is a warning, and if you neglect, 25% of patients will develop a bigger stroke.
In a matter of time.
Yes.
Somebody came to you with the TIA and you did all the scans and other things, and that shows one of their brain artery, carotid artery, is blocked. What do you recommend, Vikram?
So the main thing is it depends on the degree of stenosis. If blockage is severe, then there are two options available. One is surgically they can remove the clot. Non-surgically we can go inside the artery, we can do angioplasty and put a stent. And we can give other medications to prevent further stroke, to reduce the cholesterol, control of blood pressure and diabetes, so that further stroke can be prevented.
There is a lot of similarity, Vikram, between what you do with the brain and what we do in the heart in the event of block. I think it's the same disease process which is affecting the heart and the brain. I'm glad you're able to address a lot of these issues, because I can tell you the brain stroke may be a painless condition, but it is devastating. If somebody has a heart attack, when he's walking on the street, nobody knows that he had a heart attack. But if somebody had a stroke, believe me, it's very sad to see those people. Anyway, I think we have exceeded our time, Smita. So this is the last question for you. This is from Vignesh from Bangalore. He says, my father is 50 years old and had a stroke. He chokes while drinking liquids. He is very weak and can't eat properly. What do I do?
So if somebody is telling us that they are choking on liquids, that means the patient is eating orally and he has silent signs of aspiration. That is, silently little food material is trickling into his lungs. So this needs detailed assessment. So these patients, we need to bring, see them in the outpatient department, because these patients are the ones who are discharged sitting at home, who may come to the pulmonologist with a respiratory problem. Okay. So they will come to another department, they will not come to neurology. They have already been discharged. So they will actually have a chronic swallowing problem. So, food is trickling into the lungs and will manifest with the respiratory symptoms. So, here we need to do a detailed swallowing assessment and see what kind of swallowing problem the patient has, and then there are a lot of techniques because the act of swallowing is dynamic and you have a voluntary and involuntary part of swallowing. So, the voluntary part of swallowing, there are swallowing techniques when the patient is swallowing, you can give them the technique and prevent aspiration. So, this is how we work with them. Also, you say, sir, that the patient is feeling weak. So, that is important because when the tube is there, the patient is very comfortable. 200 ml every 2 hours is given through the tube, they do not have to do any work. But when they are swallowing, they are choking, they are coughing, automatically they feel tired, weak, and they reduce their quantity. So, there with the help of the dietitian, we need to figure out how much of input is going in, what is the safe consistency, what I spoke to you about earlier, and then based on the safe consistency, see that their nutrition, hydration and medicines can go in comfortably. Patients get discharged, they remove the tube, they come back to us in the emergency in the night, they can't swallow tablets. That is one of the biggest problems our patients have. So, they need water to swallow tablets, and tablets are huge and so many in number. So, what are you going to do? So, these are things which we need to address before the patient is discharged. So, before removing a tube, we need to see that the patient is able to hydrate himself with fluids, able to maintain his solid intake in different consistencies, manage his medication and all safely.
And it is also important to highlight in neurological patients where they have difficulty in swallowing, they have difficulty in swallowing water more than solids.
Yes.
So
really?
they can eat food,
Okay.
whereas drinking water is
More
difficult.
difficult.
So this is
Okay.
important.
Thank you very much, Vikram. Thank you very much. Thank you very much, Dr. Rao and Smita. First of all, you have taught me a lot about the stroke. A lot of things which I didn't know about the stroke, I just learned from all of you. Thank you very much. I am sure our viewers would have enjoyed interacting with you, and I am sorry there are over few thousand questions which have been asked. I could only answer about 10 or 12 questions, but let us meet next time with NH Dialogue. Thank you very much.